Dear audience, let me present my PhD topic, which is about teledentistry in the diagnosis of oral lesions. I'm Eszter Uhrin, and my vision is to make a teledentistry application in the future in order to use teledentistry in the diagnosis of oral lesions and then oral cancer as well. In order to achieve my mission, these are my specific goals. The first of these two goals is meta-analysis, which is teledentistry as a future solution in the diagnosis of oral lesions. Right now, I am at the phase of internal review. I plan to send it to language editing today or tomorrow. As a background, during the last 2 years, the healthcare and dental healthcare has changed. However, teledentistry could help in various fields, for example, with teleconsultations and triage systems. The prevalence of oral cancer is rising nowadays. The main risk factors are the following: alcohol consumption, smoking, and betel chewing, which is really common in the Far East, for example, in India and Malaysia. During the COVID and the pandemic, the non-urgent face-to-face visits were decreasing, as you can see with the orange columns. However, urgent cases were not decreasing, were not changed. This points to the fact that another alternative solution was needed in dental healthcare, which is teledentistry. To sum up, teledentistry could open a new door to oral medicine with the telediagnosis of oral lesions. I have this clinical question to fulfill this field. Is it possible to use teledentistry tools for diagnosing oral lesions? I made my systematic search in the following databases, and I have 9 eligible full-text articles. In order to make diagnostic accuracy meta-analysis, I had to make this special data extraction, where we extracted the data about different kinds of oral lesions. As you can see on the photos, the true positive lesions are quite easy to diagnose. For example, here is a carcinoma. However, using only teledentistry, this false positive lesion is quite hard to diagnose. This is a traumatic ulcerative granuloma in this case, but it was mistaken as a carcinoma as well. The giant cell granuloma, which looks like a kind of malignant lesion, however, it is not, so it is in the true negative side. As my first outcome, I investigated the detection of oral lesions. We found 0.92 sensitivity and 0.93 specificity, which means that teledentistry can substitute face-to-face visits in the detection of any kind of oral lesions. As my main outcome, I have this pooled and estimated sensitivity and specificity with 0.90 and 0.98. And here you can see two-dimensional analysis, which shows the 1- specificity and here the sensitivity. And this is our estimated sensitivity and specificity with a quite small confidence interval here. The same data is shown in this forest plot. And in this case, the sensitivity means that 91 out of 100 malignant lesions are well diagnosed with teledentistry tools. And the specificity means that out of 100 non-malignant oral lesions, 98 are well diagnosed, meaning that 2 of them are not sent only to, 2 of them need to send to referral decision. We made a sensitivity running for this analysis, which meant that in case of 2 telediagnostic person, we chose the exact others, and we got that the sensitivity was 0.94 and the specificity with 0.98, meaning that the examiner itself has no any effect on the sensitivity and specificity of teledentistry. As a summary, the strength of this meta-analysis is that the diagnosis was made only by experts. However, there are some limitations. For example, the heterogeneity of the used methodologies, and that in some articles there is no predefined referral decision. As a conclusion, teledentistry can be a substitution for face-to-face dental visits in the field of oral medicine. The implication for practice is a photo shooting protocol would be needed in the general dentistry, and also a stable technical background before doing any teledentistry examination. As an implication for research, reference standard should be changed from clinical oral examination to biopsy because it would be more objective. And also an exact lesion diagnosis should be mentioned in the articles. My second topic is about the effect of oral healthcare prevention program for post-stroke inpatients' oral hygiene. Stroke is the single largest cause of disability nowadays, but there is no such a worldwide protocol for the prevention and treatment of these inpatients. Not the dental team nor the nurses are well prepared to maintain good oral hygiene for these inpatients. Disability comes with the decrease of self-hygiene, and it means that decrease in oral hygiene as well. However, just with a little help, it could be increased oral hygiene, for example, using these specific toothbrushes. So my aim is to prevent the worsening of oral hygiene and to prevent tooth loss in these patients' mouth. I have my clinical question to do that. So, is there a significant difference in oral health status in post-stroke patients if they receive oral healthcare prevention program? And the clinical implication is to decrease tooth loss and to prevent tooth loss. Also to have a complex dental care in these PM&R rehabilitation, and also to improve oral health-related quality of life in this patient. I made my systematic search in February, and right now I am at the phase of full text selection and data extraction. So I would like to thank you for your attention with this quote, "Improvement begins with an I," from Arnold Glasgow. Thank you.
Thanks a lot. A very easy question I want to ask, and this is coming because I'm not a dentist, so it's going to sound stupid. 90–95% sensitivity, specificity sounds very promising, yes, but 5 or 10 out of every 100 person might be misdiagnosed. So my question is, how does it actually compare to face-to-face examination? What is the sensitivity and specificity of this examination in face-to-face patient contact?
Well, thank you for your question. These days in oral medicine, the basic diagnostic tool is clinical oral examination itself, and after that, in the special care, they take biopsy to to have a sure diagnosis of this examination, but in most of the cases, only examining an oral lesion can lead to a diagnosis. I mean, if you look at these pictures, from this one, for sure, a biopsy would be needed, and from this one as well. However, this one, which is a cheilitis actinica, it is very sure that this is it. I mean, in the special care, they would take a biopsy or they would cut it out, but the specialists are conducting this clinical oral examination as a gold standard in most of the cases. This is a problem with these articles, because in some cases there was a biopsy confirming this clinical oral examination diagnosis, but in most of the cases the biopsy is needed for sure. Doesn't matter if it is a benignant or malignant lesion.
I think the short version of the answer about the same, because you never know, you have to take a biopsy anyway. Yes, please.
Sorry, can we get back to the picture? Because in this case, this traumatic ulcerative granuloma, isn't it needs also a dentistry care? So isn't the patient have to go to dentistry to care, to manage this problem, or just it can work at home?
In most of the cases where there is not a malignant lesion, there is no need for such a referral and for a specialist. A primary dentist can take care about this type of.
So yes, this is what I wanted to ask, whether this questioning is, am I right that only about malignancies? Therefore, in some cases, the fact that, okay, it's not a malignancy, but also have to go to dentistry. Am I right? Yeah.
Well, in some cases, it is possible, but we would like to reduce the patient's referral decision to special care, because there are really a few oral medicine specialists in the world, and well, this is true for Hungary as well, but for example, in the Far East or in Brazil, there are like oral medicine centers where, I don't know, from 200 kilometers a person goes there, and then they have a discussion, and after that the person have to go to a blood test or whatever further examination, and after that go back to the specialist and take a biopsy. So this is like really cost-effective and time-effective, and we included.
Put it in state. This question is technically about going to special care.
The special
right?
care.
Okay,
yes.
Thank you.
Well,
sorry for
this way or that way, a dentist should be involved in these procedures.
Thank you
yes.
you so much.
But
sorry.
It is not false positive in a way, as this probably needs some kind of treatment. So I mean, I wouldn't put this into the category that, I mean, just on this slide. So that is good that you identify that, at least for first screen.
Well, in my opinion, almost every different oral lesions which are not malignant needs kind of treatment. I mean, for example, an ophthosis lesion, for example, it is painful for the patient, so we'll go to the dentist and ask for some cream or whatever. So with this examination, we would like to reduce the referred patient to special care.